Good morning, good afternoon, and welcome everyone to today's webinar. I'm Andrew Andresco, Project Coordinator for Transforming Chaplaincy, and we are delighted you could all join us. Today's title, On the Front Lines of the Pandemic, the Role of Chaplains in Moral Injury Care for Healthcare Workers. Some housekeeping instructions off the top. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio or visual, please type those into the chat box located in the platform's dashboard. You will also have the opportunity to submit text questions to our presenters by typing your questions into the questions pane in that same control panel. You may send in your questions at any time. We are going to have a Q&A session at the end. However, the presenters have indicated that should the context arise and they want to answer a question that relates specifically to what they're talking about, we will take that. And with that, I'd like to introduce Tim Ussett, Executive Director for the Physicians Wellness Collaborative. He's an ACPE certified educator and licensed marriage and family therapist, board approved supervisor in Minnesota. He is a third-year health services research, policy, and administration PhD student at the University of Minnesota School of Public Health, and he's also one of our research network coordinators. We have got about a half a dozen networks in Transforming Chaplaincy, and I've known Tim for 4 years. He's also a good friend. So Tim, over to you.
Yeah, thank you, Andy, and thank you for having us here today. Obviously, I'm here with Doctors Marci Weber and Brandon Griffin. Brandon will be leading us off, and I invite Brandon with leading us off. I'll let you share your bio and your background and what you bring into this. And Marci, you can do the same once you start, and then we'll take things from there. And as Andy mentioned, we will be, please type your questions along the way. I'll be looking at that, and we'll be happy to try to answer those during each respective part of the presentation. So thank you very much.
Well, we're very excited to be with you today to talk about this very important topic that I think resonates with a lot of folks. And so if you want to advance to the next slide, I want to tell you a little bit about what we'll be sharing today. There are 3 objectives to this talk. First, I will introduce the concept of moral injury and discuss it within the context of the COVID-19 pandemic and working with healthcare workers in particular. Second, Dr. Weber will describe some original research with healthcare workers that was recently accepted for publication. And then third, Chaplain Ussett will discuss the role of chaplains to address moral injury in healthcare workers. So a little bit about where I'm coming from. I am a psychologist by training. 75% of my time I spend doing research, mostly on the topic of moral injury, correlates of moral injury, including mental health diagnoses and issues related to access to moral injury care. I do 25% of my time in clinical practice, and so kind of have some ideas about the grassroots perspective, and I'm really curious to hear about your all reactions to the information we present today, because I think that grassroots clinician chaplain perspective is incredibly valuable. A little bit about the project that we're coming out with. You can advance to the next slide, please. This is a project that we put together at the beginning of the COVID-19 pandemic in April 2020. As many of you know, projects around COVID-19 took a lot of help. And so some collaborators, in addition to Chaplain Ussett and Dr. Weber, that were a part of this project are Dr. Smith and Langenecker from the University of Utah, the Knight from the Lyda Hill Institute for Human Resilience at University of Colorado, Colorado Springs, Dr. Shira McGinn at University of California, San Francisco, Dr. Irene Harris from the University of Minnesota in VA, Maine, and Dr. Jeff Pine from the University of Arkansas for Medical Sciences. So what is moral injury? There are probably a number of things that we have all heard on moral injury. I think with the COVID-19 pandemic, it has received a lot more attention, but the definition that I tend to practice from was introduced by Dr. Brett Litz in a paper in 2009, who suggested that moral injury refers to the psychological, biological, spiritual, behavioral, and social impacts of perpetrating, failing to prevent, or bearing witness to acts that transgress deeply held moral beliefs and expectations. So when moral injury was initially introduced, it was primarily within the military health literature. And since then, it has transitioned to more civilian settings. So now we're talking about moral injury in the context of healthcare workers, moral injury in the context of educators, moral injury in the context of civilian authorities in support of Border Patrol. So it has really expanded its breadth in the last couple of years to apply outside of just the military health setting to a number of other professionals. I think one characteristic among many of these is that oftentimes it involves people who are working in a situation where they make critical decisions, often with limited time and information, and under difficult situational constraints and emotional duress. And so one thing that I want to be very clear about is that moral injury isn't simply referring to veterans who are exposed to war atrocity or healthcare workers who are involved in some kind of medical error. A person can participate in gold standard practices. They can execute the responsibilities of their job. They can follow all of their professional codes, use of force standards, whatever. They can do things right and still walk away with a moral injury. And I think a reason for this is because of the nature of the events that we tend to be exposed to that can precipitate a moral injury. If you could give me the next slide, please. So one of the things about these events is that they often, there are often overlapping ethical standards that apply to a single event. So you could imagine here, we have given some examples from a military setting. Of course, we would never share the story of a specific person that was involved in our practice, but these are some common themes that have shown up in the literature in a number of places that we've put together. But in the context of a military setting, you can think about folks who are involved in operations where there is harm to a vulnerable non-combatant, especially women or children. Perhaps inability to prevent the injury or death of fellow service members, use of disproportionate force or excessive violence, witnessing suffering due to poverty, famine, subjugation. One thing that stands out to me in a number of these events is that there are overlapping and conflicting ethical codes. So if you think about perhaps a child is instructed to approach a military checkpoint that a service member has been instructed to maintain the security of. In this case, many of our service members are going to feel care for a vulnerable person, this child who's been instructed in approaching a checkpoint with a firearm, but they also have obedience to authority, the job that they've been given to maintain the perimeter there, as well as loyalty to their fellow service members that they're there to protect. So now you've got at least 3 ethical standards operating in the same context, where it's obedience to authority, care for a vulnerable person, loyalty to fellow service members, and there's an inevitable sense of transgression. No matter what decision they made, it's going to transgress one of these situations. And I think that just speaks to how multiple moral perspectives often apply to these situations and can precipitate a moral injury. With the context of COVID-19, we have really seen some of the features of these events that were originally described in a military setting show up in a healthcare setting. So failure to prevent transmission of infection to a vulnerable person. Many healthcare workers felt a duty to serve the public in using their essential training and skills in order to alleviate the burden of surges in COVID-19. They might also have immunocompromised family members, children, elderly parents who are at home. So many times they would be feeling like they are prioritizing sort of duty to the medical field over their role in the family and putting their immunocompromised family members at risk. Another is restricting access to testing or interventions due to lack of supply. There were times during the pandemic when we've heard a lot about restriction of access to ventilators because of issues with supply, and making decisions about optimizing individual patient outcomes according to the likelihood they may benefit or not. And so I know that there have been many who have felt the weight of they want to be a part of optimizing individual patients' outcomes. People got into the medical field because they care about others. But in situations where there is lack of supply, they have to make judicious decisions from a public health standpoint about who is most likely to benefit from these. And in those cases, it can feel like you are, not giving everyone their best fighting chance. Also, enforcing safety precautions that do collateral harm. If we had a person who was dying of COVID-19 or complications related to the disease and had to prevent family members from being around when that person was passing, and those kinds of safety precautions, but that they do have ripple effects that nurses, health techs, physicians may feel responsible for. And then finally, witnessing disparities in testing, care, and survival of infected persons. So we have seen a lot about how there are racial differences in testing, care, and survival related to COVID-19 and the disproportionate impact of that disease on underserved communities. And so people can witness the suffering and feel like they are limited in their ability to do more. They can feel complicit in public health policies that maybe negatively impact these populations. And all of that can be a source of moral injury, or what we would describe as a potentially morally injurious event. Next slide, please. So scholars have been really interested in moral injury recently. You can see there that first article that I was mentioning that described a definition of the construct showed up in 2009. So there were a few articles that were published along those years, but as you can see on the x-axis, it was around year 2015 that things started to pick up, and then really accelerated in years 2021 and 22. So you can see kind of the rate of that climb increase. And I think a lot of it was because of COVID-19 was just like throwing gasoline on a fire, particularly by extending the applicability of the construct from military populations to healthcare workers. It's not just clinicians and scholars who've been interested in moral injury either. You can see that it has shown up quite a lot in general media outlets: the Washington Post, BBC, Huffington Post, Atlantic, New York Times. All of them have been talking about moral injury. So I think that this is a really important area for us as members of the spiritual and mental health care community to be working together to address this need that the public certainly recognizes. I'd like to share a little bit about just how I tend to conceptualize moral injury. So here you can see on the left side of the figure the potentially morally injurious event that might happen. So we could maybe think about prioritizing a public health policy about withholding a ventilator from someone who potentially is not going to benefit very much from it. In this situation, if we were thinking about maybe nursing staff, they would be developing attributions or cognitions about this event. They probably sound like, I should have been able to do more in this situation, or I didn't do everything I could to help that patient. They feel some degree of complicity in what had happened, especially if that patient experiences a negative outcome like death. Those attributions can prompt distressing negative emotions: shame, guilt, anger, disgust, feelings of powerlessness or horror. And oftentimes you'll see changes in functioning. And so some people will do what I would refer to as over-functioning by patients, where they are trying to atone by seeing more patients, taking more into their caseload, and maybe even withdrawing from coworkers or from family members as they try to make meaning out of these difficult emotions that they have felt but have difficulty finding support to do so. In those cases, oftentimes individuals will experience self-condemnation, and if the value that they're condemning themselves for, like care for a vulnerable person, is something that they think might be shared among their fellow coworkers or among their family or among individuals in their religious or spiritual communities, oftentimes they will perceive rejection from those people. So I'm likely to perceive rejection from others if I'm condemning myself for something, if those others share values with me. And in those situations, we can have difficulty forgiving ourselves, difficulty forgiving others, that all sort of spins us up into this cycle that can lead to morally injurious outcomes related to difficulty meaning making, higher risk for mental health problems, loneliness, functional problems like disengagement from work, substance use issues, feeling like you don't deserve healthy relationships, good jobs, that kind of thing. So all this is happening at the event-specific level. And if you'll give me the next slide, please.
Brandon, I'm going to jump in quick. We have a question. Someone asked, does this construct of moral injury, does it cover those that have experienced as general abuse or sexual trauma, or victims of trauma that they couldn't stop? I guess that could be in any population, if you want to speak briefly to that before going on to the model.
Yeah, that's a fantastic question. So we know that if a person has experienced one trauma, they likely have experienced other traumas. And so it would be common to, if a person was a victim of betrayal trauma, like a sexual assault, abuse, neglect, that they would be at higher risk for moral injury. So we know that from some studies of Canadian service members who experienced adverse childhood events. And I think a reason for that is that if you have been the victim of trauma yourself, it's easy to identify with the victim of other traumatic events and feel complicit. So there are differing opinions within the moral injury literature about what exactly is betrayal trauma, what is PTSD, what is moral injury, but I would definitely say, based on the research that exists, that a person with a past history of trauma is likely to identify with the victim and then feel complicit if they think the organization that they belong to is doing harm, or that they didn't do enough to step in when they may have could have. Does that make sense?
Yeah, thank you.
Perfect. So within this event-specific process, it happens within the context that involves individual factors, interpersonal factors, organizational factors, and even societal factors. So you can think about how even that question that we just got at the individual level, there are factors like trauma history, also religiousness or spirituality, maybe how concrete someone is in their spiritual thinking, or how abstract they are in their spiritual thinking to negotiate these differing moral perspectives. Different messages we get about moral injury that are based on gender or race, that all of these can impact sort of the attributions that a person develops and how this process unfolds. Similarly, bonds that we have with family, friends, coworkers, with important groups like religious and spiritual communities that we belong to, they can affect how that process unfolds. And particularly within healthcare populations, we know things like organizational support, feeling betrayed by leaders or systems within the workplace, and that shared sense of purpose or group cohesion can play a role. All of these factors can affect how the process of moral injury occurs, but also outcomes related to moral injury fold back in through these feedback loops into different things like at the individual level, you can have cumulative stress, disillusionment about the future. We've seen a lot of turnover, especially among nurses who've been impacted by COVID-19. It should matter to organizations because these outcomes likely contribute to workplace absenteeism, increased training costs when we have to fill new positions related to staffing, low morale and productivity, and even disability costs, as we know that morally injurious outcomes is related to things like mental health issues and other problems. So in sum, I would say that moral injury is an individual syndrome that that happens when people are exposed to specific kinds of highly stressful events that are morally salient, but that it is impacted by individual, interpersonal, organizational, and societal factors. And I will turn this over to Dr. Weber, who's going to unpack this for us in the context of the data we collected.
Thank you. So I'll go ahead and introduce myself briefly. I realize the slides and my name on the screen say Marcela, but I do go by Marci Weber. And I am a postdoctoral fellow with the VA in Arkansas, where Dr. Griffin also works. And like him, I'm part-time a clinician and part-time a researcher. And so My clinical work is primarily, both clinical work and research are primarily around the topic of trauma, PTSD, and I am also coming at this from a resilience background and a resilience angle to my work. So for me, my own experience of COVID-19 has partly been as a clinician providing, as a healthcare worker providing mental health services during COVID, during a time when a lot of these things were happening, including in the VA system. So there's certainly a personal piece to some of what we're covering today, since I think probably most of you all listening in and those of us giving this presentation are also, we're talking about ourselves here in a way. I just want to mention that. And sorry, I just now saw some questions pop up. Tim, I'll let you tell me, you interrupt if you think I should take a question.
Yeah, no, go ahead. Some of them I just answered by text. I want to acknowledge there was a question about how moral injury is different from clinical depression. And I think that kind of goes outside the scope of what we're talking about today, but I will maybe write something about that, but nothing you need to attend to. So keep going.
Okay. So like I mentioned, I'm going to be covering a specific study that we did with a research study that we did on moral injury amongst healthcare workers during COVID-19. And some of the questions that we wanted to answer with this particular study were, what kinds of moral injury are healthcare workers experiencing? How much are they experiencing? Dr. Griffin shared that conceptual model with these sort of system level factors and spoke about the institutional betrayal piece. And so we wanted to know how betrayal fits in with the moral injury that healthcare workers are experiencing. And how does it impact their lives? How is it impacting their work performance, their relationships, their self-care? So those were the topics that we're trying to answer with this particular study. You can go to the next slide. So we surveyed 480 healthcare workers who were working in the Rocky Mountain region of the US when we surveyed them in fall 2020. So if you all think back to fall 2020, which you may not want to do, but think about what the context was of being a healthcare worker at that time. This was a time when hospital systems were overburdened, when there were shortages of supplies, like the examples Dr. Griffin gave, including ventilators and PPE and things like that, were in short supply. Remember, this was before vaccines were developed and available for COVID, and so that was part of what made this a more stressful time to be a healthcare worker. And even if people weren't directly working in COVID units, the system was strained and experiencing a lot of shortages of staff and supplies and all these things that made this a particularly stressful time to be providing healthcare. And all of the workers in our study would constitute essential workers, and most of them were providing direct clinical care to patients. So that included nurses, physicians, and other direct clinical care providers like technicians, mental health clinicians, radiologists, physical therapists, other health professions involved in direct patient care. You can go to the next slide. And so we gave them an online survey that included questions about exposure to potentially morally injurious events, and also questions about distress from these exposures, and questions about feeling betrayed by the system. So I put in italics some example questions, and I picked this example because I think this is a type of moral injury that may be a little bit more confusing to wrap your mind around. So for the exposure question, the example I gave is, I violated my own morals by failing to do something that I felt I should have done. So this is a question that's asking about an instance in which you feel that you perpetrated a moral transgression by not taking any action, by your own inaction or by what you failed to do. And then the question about distress around this kind of exposure is really describing the same kind of event, but the question asks, I am troubled by this instance and what happened. And then we did also ask a questionnaire about psychosocial functioning. So how well people are doing and what problems they're having at work, in their personal relationships, and in their personal care. And the psychosocial functioning questions asked, how have you been doing over the past month? So I'll get back to the functioning piece in a minute, but first I just want to go over what we found about the types of moral injury and healthcare workers were experiencing and how much. So the group that we called minimal exposure was about a little less than a quarter of the people in our study who didn't report very much systemic betrayal. They didn't report very much witnessing transgressions or perceived perpetrations. That's not to say they didn't have any at all, but there was a significant difference between how much they were reporting and then the rest of the people in the study. The betrayal only group was healthcare workers, and this was the largest group. This was healthcare workers who reported feeling betrayed by their healthcare organization, their government, their community, their institutions. They were reporting kind of a general sense of betrayal, which wasn't the same as specific instances or specific acts that they had witnessed. The group that we called moral injury other did report that systemic betrayal, but they also reported that they had witnessed potentially morally injurious events in which other people, other individuals had done something that transgressed the respondents' moral beliefs. I just want to point out that most people who had witnessed transgressions also reported systemic betrayal. There wasn't like a group of people who had one of those without the other. And then in the same way, those that we called the moral injury self group, these were people who reported that they had perpetrated a moral transgression. So they felt like they had done something wrong through their own actions or failing to act. And that also typically happened alongside having witnessed moral transgressions by other people and feeling betrayed on the systemic level. So you can go ahead and switch to the next slide.
Marci, I'll jump in quick. So there was a question, any chaplains included in the research? So my sense they're asking, were there any chaplains in the sample is the question.
I believe there were. It would have been a pretty small percentage. I don't remember off the top of my head. There were a few, but other than the nurse, that's why I kind of on that graph broke it down by nurse, physician, and other, because pretty much all of the other healthcare provider or healthcare worker categories was a pretty small percentage of people. But that's a good question.
Yeah, thank you.
So this is another way to look at those same things that I was showing, the same findings I was showing on the last slide. This is our sort of theoretical model making sense of the findings that I just presented on. And that is that betrayal is the context of moral injury. So most moral injuries happen in healthcare workers is happening in systems where they feel their institutions, organizations, and community have done something wrong or harmful. That's when they are typically seeing other individuals transgressing their morals. And in the same way, in settings or contexts where they are witnessing transgressions by others, that's when they are more likely to feel that they have perpetrated a moral transgression themselves. So one takeaway from this is that, yes, moral injury is an individual level problem. It's an internal experience that, like Dr. Griffin said, is partly psychological, it's partly spiritual, but there are also systemic problems that are placing healthcare workers at risk of moral injury. These settings where they feel like the system the system is broken and causing harm, those are the settings where moral injury is happening on the individual level. We can go to the next slide. And so this is where we looked at and compared each of those 4 groups of healthcare workers for how much their sort of type or extent of moral injury was causing problems in other areas of their life. So the way to look at this graph or this chart, the boxes in darker blue shows that this group was more impaired in that way than the other groups on the same row. So for like the first row, I guess it's technically the second row, the total psychosocial impairment, this was combining all of the categories that are below it. So for total psychosocial impairment, the people in the minimal exposure group doesn't mean that they weren't having any problems at all, but they were the least impaired compared to betrayal only, moral injury other, and moral injury self groups. And so overall, the people who were in the betrayal only and moral injury other groups had some impairment, and it wasn't that different across those 2 groups. And then those in the moral injury self group, those who, remember, those are the people who have betrayal and have witnessed moral transgressions, and they believe that they have perpetrated a moral transgression. Those are the people with the worst impairment or the worst functioning overall. So for some areas of functioning, the folks with betrayal only and those who had witnessed transgressions had about the same impairment. That would be for family relationships, friendships, and personal care. And then for work and romantic relationships, those who had witnessed moral transgressions by others were doing worse than those who only had a sense of systemic betrayal. And then if we look at work functioning, that second to last row, each group with greater moral injury was doing worse than the last. So while the moral injury self group was the smallest, there were only 11% of healthcare workers were in that group. Those were the healthcare workers who had the most psychosocial problems by far. And this includes their problems on the job. So when people feel their own actions at work transgress their moral beliefs, this is causing pretty significant problems to their ability to do their work well. Like I mentioned earlier, all the folks in this study were essential workers, and most of them were providing direct patient care. So our findings suggest that moral injury is a major risk factor for the quality of healthcare that patients are receiving, considering it was having this impact on their work functioning. The other key takeaway that I want to highlight here is that over 3/4 of healthcare workers were experiencing at least some betrayal and some psychosocial impairment. So there is clearly a need for psychological supports and spiritual supports for the majority of these healthcare workers, the majority of the healthcare workers who have served during the pandemic. And those with perceived perpetrations, or those in the moral injury self category, are probably the ones who need the most support and need interventions the most. So that is where I leave off, and Tim can tell you all more about the kinds of interventions that chaplains can help with for healthcare workers with moral injury.
Thank you. One more question for you before we go into meet, and it was related to, was moral injury from societal pressures versus institutional or hospital pressure measures? So my sense is, did the betrayal question account for differences in where the betrayal came from, is how I'm reading that.
I'm not seeing that question, but that is a really good question. Say it again, societal pressures?
Yes, from societal pressures versus institutional / hospital pressures.
Gotcha. So there were several different questions that, like there was one question that was specifically feeling betrayed about your healthcare organization, another question about your local community. So we did capture each of those things separately. The reason I combine them when I explain the findings is that people who who reported one of those betrayal types tended to report the others. Once Tim moves on, I will look back at some of our more specific findings, because it was a little different for each question, how much betrayal people were reporting. But if they felt betrayed by one system or one institution, they were mostly reporting that they also felt betrayed by the others. So that was why I kind of combined. But that is a good, I'm glad somebody brought that up, because those are important distinctions, like who are they betrayed by? And in particular, in this case, feeling betrayed by the healthcare organization that they work for. I think that was an important distinction compared to just feeling betrayed by society as a whole or something like that.
Yeah, one more question for you, Dr. Weber, and then I'll go on. But it was the question was, how much time elapsed between the PMIE and these assessments? So I think that's asking, were we assessing time from when they experienced these PMIEs and when the survey was done? I think is how I'm reading that.
Yes, that's a good question. I will double check and I will correct what I'm about to say if I'm wrong. But I believe it was worded as since the start of the pandemic. So remember, we were surveying them in fall, so that was give or take, over the past 4 to 6 months, whether this had happened at all. So that doesn't mean that they were, feeling like they perpetrated a moral transgression every day. It just means essentially at least one time since COVID started. Any other questions? Two questions.
Yeah, well, there's several more, but we'll come back to them at the end here. So you can go ahead. Next slide, please. So good afternoon, everyone. My name's Tim. I want to start off by thanking, of course, Transforming Chaplaincy for hosting us, and Dr. Weber and Dr. Griffin for inviting me to be a part of this project with them. It's been a lot of fun, and I think the culmination of this work, seeing the paper published, accepted recently, is very cool to see. So we've talked a bit about the background of moral injury in this study specifically, but now we're going to talk a bit more about, well, why chaplains, or specifically, what do chaplains have to offer healthcare workers in this space? And before I even answer that, one of our other questions was, well, what happens when chaplains themselves have these morally injurious experience, and how does that impact how they may care for staff members? And I think, as one of us already mentioned, maybe it was Dr. Weber or Dr. Griffin, one of the two of them said, we're not talking about other people, we're talking about ourselves in this. And I think that really connects with, we all, many of us are healthcare workers in different contexts, and these things do happen to us. And without going too far into the weeds there, well, I want to come back to that at the end. But I think, again, when we look at that, those impairment is a loaded term with clinicians, but if we're starting to experience not just the events, but a lot of the distress associated with the events, that's an indication that we need to seek care ourselves. I think is the shortest way to talk about that. But I do want to talk more about what is the unique role of chaplains in addressing moral injury as it's now being evaluated and studied in healthcare context with healthcare workers. And I think one thing that chaplains has is we still have a relatively unique role within institutions. And that happens on a number of different areas. And this varies by institution, by a private context, maybe compared to by a federal context. So for one example, one interesting thing about chaplains in the military, of which we have chaplains working in military healthcare contexts, and this sometimes is true in VA context and sometimes in private health systems, is chaplains sometimes have a unique role as an advisor to high level or executive level leadership in their organizations. So they have access to give those leaders, I don't want to say advice, but advise them on issues that are impacting the morale of employees. And so when we see that roughly 41% addressing this betrayal piece, now not all of that may have been from their healthcare organization, some of that could have been societally, those sorts of experiences by healthcare workers are really important for leadership to note, because, and if chaplains can advise leadership, are there policies we can change, or what I like to often talk about, how can we bring congruence here between what we're asking our healthcare workers to do and what they're experiencing us asking them to do. And I can see that's where betrayal can easily take place, or at least have that experience, especially in the pandemic where things were changing so quickly. So many people were so overwhelmed. Policies were changing sometimes daily, if not by hour, if not by week. And that really was an environment that allowed that experience of betrayal to become very common. The other part that I think is important to note about chaplains and institutions, somewhat compared to mental health professionals, is that we often have a dual role of both patient care and staff care. And that's, I guess we could say, in part, that might be the benefit of us usually not being billable compared to other professionals who are billing based on a certain type of patient care. But because we have that dual mandate, we are well positioned to provide care to staff that have experienced potentially morally injurious events. As has already been talked about a little bit, chaplains are somewhat unique in our training around working with religion and belief systems, and more specifically from a pluralistic lens, and that we are working within people's faith constructs or meaning-making constructs, but not necessarily prescribing religion or meaning-making constructs to them. And so much of these experiences of moral injury have at least a part. Well, Brandon already talked about these multiple moral contexts or mandates. We'll talk about that a bit more in a minute, but they're at least in part coming from people's religious, spiritual, or belief system values. Another part, which is true about chaplains, of course, is the way that we are trained in spirituality and religion, but many of us also have training in mental health, not necessarily as a mental health clinician that's going to diagnose and treat a specific mental health condition, but through our work in clinical pastoral education in a healthcare system or through some of our degrees, we are at least familiar with the mental health world. And I know that may vary a bit by where we trained, but that's something that I think is really important when working with moral injury and healthcare workers, is that we have all of these worlds of value, religion, and spirituality meeting different mental health concerns. And it looks like I've already talked about my last bullet around the advising leadership part, so let's go to our next slide. So as I said, Dr. Griffin talked about multiple moral contexts or mandates relative to these potentially morally injurious events. So that means that we have multiple right answers or even multiple wrong answers in these different situations, especially with the pandemic and what many of the decisions that healthcare workers were facing. So one helpful model that I've worked with Dr. Irene Harris on and others is this Fowler's stages of psychospiritual development. And what it is, it's a model that looks at how do we hold our values and beliefs, whether they're specifically from a religious or spiritual tradition or not, and how do we hold them relative to differing values or beliefs. And if we look at, we don't need to get into all of the stages, but looking at that stage 3, many of us are at that more, I hate to use the term rigid, but somewhat rigid place, in that we have our belief system, we have who we trust about our belief system, whether that's a specific faith leader, a specific ideology, specific way of reading a sacred text. And when we encounter a belief paradigm that has different moral implications or beliefs about a situation, we have a collision there. And so when we have these challenging situations in healthcare or in the military where there are these colliding moral contexts, it's really hard for us as humans to integrate that. And so the hope of some of these interventions that we'll talk about in a moment is that we want to give people the opportunity to integrate multiple moral contexts. And I don't mean that from the perspective of moral relativism. That's not necessarily what I mean, but it's from the ability to hold the tension of these competing contexts in a way that we can hopefully reduce distress, or at least, I hate to use the term, put our distress in context. So let's go to the next slide. So one intervention that came initially out of the military and service member and veteran population was building spiritual strength. And this intervention is currently being adapted to work with healthcare workers And the core parts of this intervention are really looking at giving people in groups. It is a group intervention, and it can be led by chaplains or trained behavioral health or mental health professionals, ideally one of each. And then it gives either service members or veterans or soon-to-be healthcare workers the opportunity to share stories and values, experience sharing what's very distressing to them, and receive feedback from multiple moral contexts, this being the facilitators and group members, about what's causing them distress, about their, again, whether it was a single event or multiple events. And from there, the group works together, both experientially with the sharing and receiving feedback, but also through prayer and meditation logs, working with their higher power, if they're a person with a higher power, to do these exercises individually and as a group. And again, with that broader perspective of we want to help people integrate multiple moral contexts, and through that, be able to access compassion towards self and compassion towards others. And those are two themes that we'll see in these other interventions here in a moment. Lastly, it's important to note we do devote some time in here specifically to forgiveness and reconciliation. And what's very hard, and I want to move towards more questions here, but what's very hard about potentially morally injurious events is that people will have this experience or sense of guilt about what has happened, either what they did or what they witnessed or what they saw happen. But generally speaking, they didn't actually perpetrate a wrongdoing. So that's what makes it so tough to work with these issues. But let's go to the next slide. Evidence for BSS, we're going to move quickly here because I want to get to your questions, but there's a couple clinical trials that had promising results. In the adaptation of health and strength, we're in the process of getting tested in a few different places. You can note the website on the bottom in terms of the VA's diffusion marketplace if you want to learn more about how you could be trained in building spiritual strength. Let's go to the next slide, please. So other treatments that exist in this space, and it's important to note most of these, not entirely, but at least had some of their basis in the service member and veteran population. The self-forgiveness workbook, I think Dr. Griffin can speak to more places with that, but I think that's been tested in other populations too. But all of these interventions are looking at how do we facilitate compassion towards self and compassion towards other following potentially morally injurious events. Some of them are doing that through experiential groups such as building spiritual strength. Some of them are doing that through different loving kindness or meditation practices. Some of them are doing that through different journaling or letter writing, experiential processing with the therapist or facilitator. And again, I would say take a picture of the slide. These are all good interventions. Some of them can be done by mental health professionals. Right now, the self-forgiveness workbook and building spiritual strength are the only two that really fit well in that chaplain-led space. But let's go to the next slide, please. So yeah, we're now at questions. I know we have about 11 minutes left, and give me one moment here. I will open up the question box and we'll start to read off some of these questions that have been coming in while I've been talking. And actually, but let's start this off. So either Dr. Griffin or Dr. Weber, we had that question earlier on, how does this relate to clinical depression? And I think I'll reframe the question to say, how does moral injury relate to different DSM diagnoses? And maybe a brief couple-minute response to that as I look at these other questions.
Yeah, I can take that one. So that is such a good question. I think there's a few important things I would like to emphasize. The first is that major depressive disorder, post-traumatic stress disorder, these are formalized disorders with objective criteria that can be evaluated to determine if someone meets the clinically diagnostic level of a given disorder. Moral injury is not a formalized diagnosis, and there is a debate within the literature that is, I think, a really important point to consider. In some cases, it seems as though moral distress in response to being exposed to these potentially morally injurious events is a sign of an intact moral conscience. You know, so we don't want to over pathologize the guilt that a person may feel. You know, we don't want to tell them that the distress that they're experiencing, they shouldn't be experiencing, right? They get to pick their values. the event was unusual and transgressed those values. And so I think it's important to acknowledge that sometimes those feelings that you have are a sign of an intact moral conscience. Specifically with reference to major depressive disorder, but also characteristic of the other disorders, we know that there are a few differences here. So one difference is in response to clinical presentation. So we often see moral injury is anchored back to a specific event or series of events, whereas major depressive disorder is not like that. There is no criterion A event for major depressive disorder like there would be for PTSD, and that's a way that sometimes we think about PTSD and moral injury as both sort of stress-related syndromes because they're anchored back to a particular event or series of events. But there are differences in clinical presentation. There are also differences in clinical course. Moral injury has become more a topic in civilian settings very recently. So there's not great longitudinal data out there that's looking at non-military populations. But from the longitudinal studies that have occurred in military populations, we know that someone may have been exposed to an event maybe in which a woman or child was harmed while they were deployed, and they may not show clinically significant symptoms until they separate from military service years later, right? Like while I'm connected to service, while I'm connected to the institution that I'm working for, maybe I displace responsibility onto my leadership who gave the order. Maybe I displace responsibility onto the group, the unit that I was a part of, my coworkers. But it seems like when people separate from service, and sometimes when they start hitting developmental milestones, like having families of their own, maybe beginning to have children, these sorts of things that are common among the age at which many service members choose to separate, that we see the moral injury syndrome kind of showing up much, much later than after when the event occurred. And so I think that's going to be something that's interesting to watch among healthcare workers, especially those who might be separating from their service, who might be deconverting from religious or spiritual groups, that kind of thing. And the last way that I'm thinking that it might be different from, that moral injury might differ from PTSD, major depressive disorder, is in terms of treatment response. And so this is a question that is still waiting to be answered, but it is often the case that the interventions that Chaplain Ussett has described are paired with as an adjunctive treatment for other like evidence-based treatments for major depressive disorder or PTSD when moral injury and these disorders co-occur. So we know that if the clinical presentation is different, if the clinical course is different, and if the treatment response is different, it starts to look like we're dealing with separate constructs here.
Thank you, Dr. Griffin. I want to fire off a couple quick responses. There was a question about how there being connections between potentially morally injurious events and healthcare workers leaving the workforce. I know there are good connections with that with burnout. I don't know that there's good connections to that with PMIEs yet. Do either of you know if there's any literature linking that?
There have been a number of editorials published that would suggest as much, and I don't think it's a big step. We have in the data that Dr. Weber shared some scales about turnover intentions, like if people are thinking about leaving their job, how interested they would be in seeing another opportunity, and we're seeing a mass exodus, especially among nursing personnel from hospitals across the country. And so I think that that exodus is probably multifactorial, but that moral injury certainly could contribute some to it.
Yeah, thank you. I know a couple questions came in about how do we work with these things around people who don't have a sense of spirituality or a higher power. And I think what's important to note about any of these interventions, whether they're chaplain-led or mental health-led, we are working within a person's belief system. The more explicitly spiritually integrated ones, such as building spiritual strength, we've had numerous atheists and agnostics go through groups, and instead of a prayer log, we call it a meditation log or reflection journal. So we make those adjustments, again, in any of these interventions, real time to affirm and support the belief system of whomever it is that's engaging in the intervention. So that was a really good question. Another question about either Dr. Weber or Dr. Griffin, have either of you done face-to-face interviews, any qualitative interviews around this with healthcare workers yet?
I haven't, and I think that, you correct me if I'm wrong, but I think that most of our research has been quantitative, but there is qualitative research that's being done about this, and I would say that's where some of the background examples that Dr. Griffin gave about the kinds of potentially morally injurious events that healthcare workers are experiencing. Some of those have come from qualitative studies or case examples that have been published about this kind of thing. Like a common example I've seen is, or a qualitative description of a potentially morally injurious event in the context of COVID is the shortage of ventilators and feeling like you can't, I mean, like there's no way within this system to do what you think is right and give the care that you believe the patients deserve to every single person. But the other example I've seen, I'm sorry, I'm not doing very well with it, looking at the chat. Someone brought up a question about visitation or something like that. And I think that's, I don't remember what exactly I'd seen in the chat, but I think that's another qualitative example that I've seen is having to deny visitation to family members during this is something that has happened before that healthcare providers have had to deal with since before COVID, but during COVID, there were much higher rates of rules that patients cannot see visitors. Visitors are not allowed in the hospital, even if someone is, even if they want to come and say goodbye to a family member who's about to die, that visitors are not allowed. And so having to deny visitation could be a potentially morally injurious event that I've seen in the qualitative work.
I can say that the sample that Dr. Weber presented today, that there's a follow-up qual study, that a portion of those who participated in the parent study gave us permission to follow up and do more in-depth interviews. So we're chasing them down right now. And there have also been a number of good qual research coming out from other labs. So one that I'm aware of is Lauren Borges. She has done some qualitative work around moral injury in healthcare workers that I thought was particularly instructive and that has kind of shaped some of my thinking on these issues. So we're both, Dr. Weber and I are more quant people, but seeing the qual work that's been coming out has been really nice to sort of pair these different perspectives in order to understand the experience of moral injury among healthcare workers.
Yeah, I want to acknowledge the time. It's 12:59. We have a couple more questions that we're okay, or I should say I'm okay going a couple minutes after the hour, so we'll try to answer these. I know there was another piece on the qualitative side. I know Chaplain Paul Galshut did a study with some inpatient palliative care chaplains and has published that relative to that. That was more the patient-focused experience, but there will be a follow-up on the actual chaplain's experience of providing that. And I know moral injury / distress emerged as a theme in some of those interviews. Another piece, I know someone brought up moral distress earlier in the questions, and we don't have time to solve that today, but moral distress, we could call it a parallel or related construct that did originate in healthcare, and they have been studied separately. I know there's been one scoping review published. I know I'm part of another scoping review looking at the two terms within military health professionals. And I think with the time we have today, the simplest way to put it is that moral distress does not account for violations of one's personal beliefs. It accounts for violations or incongruence relative to professional values or ethics, whereas moral injury can account for personal or professional. In addition, there's the betrayal component of moral injury. So I don't know that we're going to solve the differences in those constructs, but I at least wanted to name that they do exist, they are similar, and they also are different.
Tim, I think one thing that has been helpful in my practice has been talking about that these events tend to occur on continua of frequency and severity. So less frequent, more stressful things, or more stressful things tend to happen less frequently, and less stressful things tend to happen more frequently. And so sometimes I think about, we are all exposed to moral challenges in the practice of providing healthcare. Like ethics is a part of chaplaincy training, psychologist training, all of it. And so that is to be expected. But there is a level at which a person might experience clinically significant distress that becomes impairing in terms of their functioning, like Dr. Weber presented. And I think for me, that is the differentiation between moral distress and moral injury, is like, where do we cross that line of an event might be more rare, but cause enough distress to where it is impairing a person's functioning.
Yeah, well, we had another question here, and I'll let either of you take this one because I know I would go on, but it's looking at the experience of COVID-related stressors being externalized, or the distress being externalized by located in the system and in others, and is externalization or depersonalization healthy or helpful? Which I know I would go on too long, so do either of you want to briefly answer that?
I can speak. Okay. I can speak with this, and I should give the disclaimer that the views we're expressing today are our own and not the opinions of the U.S. government, Department of Veterans Affairs, or our academic affiliates. But I would say that to some extent, stress is better out than in. So we know from treatments like acceptance and commitment therapy, where there are interventions that you displace distress to a more appropriate sort of reactive area, and that can be helpful to blow off some steam, you know, in the common vernacular. I think that moral injury, the way that with healthcare workers that I've interacted with, the way that we tend to talk about it is a lot like burnout, that this is an individual syndrome that has causal roots in organizational problems. And so oftentimes we can improve our self-care, we can utilize our social support systems, and those can help us to increase our tolerance of the distress that we're experiencing. But we can't self-care away the problem of moral injury. And I think that that is one reason why chaplains are so uniquely positioned when they have the ear of administration, because they can be a critical part of advocating for the well-being of healthcare workers by addressing these important issues that are affecting the well-being of the frontline personnel.
Yeah, I think that's great. And I think there's always when it becomes too much the other as the problem or the betrayer, it's so easy to be just simply consumed with bitterness and resentment. And so in that sense, externalizing isn't helpful. And that that truly takes on specific units, specific hospitals. It really can become organizational culture. And that just can be really tough.
So everything in moderation.
Yeah, everything in moderation. And good call, Dr. Griffin, on reminding everyone that anything foolish we say is not from our organizations, and it's only from us.
One other thing I'll tack on about that is that, I'll just mention again what our findings were and why I showed that kind of nested model, you know, that people who are feeling like they are to blame or like they did something wrong, that's happening. There's not really a group of people who are saying that they did something wrong and they didn't also see this happening as perpetrated by others, and that's not happening without the sort of system level problems being reported. And what's the other thing I was going to say about that? Oh, that, you know, different healthcare workers have different, depending on their role and their position, not everyone has the same amount of power and control in the system. And so in some cases where there may be differences in how much people are, you know, saying that they're seeing other, how much people are blaming the system or blaming other individuals, you know, some of that may be also founded in how much how much control that person has. Certain healthcare providers get and have to make more decisions that carry more weight than others. And so, that may be a factor in who is reporting that they are to blame versus other people or versus the system. If that makes sense.
Well, I think that's a really great point, Dr. Weather. You're just looking at power differentials, but if we even look at an overlay around more broader inequity, whether it's related to gender or to race, and those pieces, there's not formally an interaction term, but there may very well be, and how that plays out both positionally and by social location. So there's a couple more here that I want to at least acknowledge. One was looking at what does it mean to forgive self when wrongs are done by others, and where is a God or higher power in granting that forgiveness? I don't know that I'm not going to truly answer that, other than that say that's a really good question, and I think it's really important to work deliberately with that question when working with healthcare workers in this area, because there's so many different parts of our own agency in these areas where we see others falling short. Or I've even seen situations where I'll just say it was me in this case. I experienced a betrayal by an authority figure in a healthcare institution, and that authority figure was actually doing their job, and I would have done their job in the same way. So it's interesting when you can look at it in terms of, it doesn't mean that leaders are necessarily doing bad or wrong things. It may simply mean being in a position of leadership may result in people working for you experiencing betrayal, which I don't know that makes things any easier for us in terms of what to do about it. But I think it helps us if we think back to that psychospiritual development model. It isn't purely right and wrong. There's many moral contexts and mandates that are in play. All right, there's another question here about grief work involved in these treatments. And you note there's a DSM diagnosis for prolonged grief disorder. Again, I want to acknowledge this and simply say yes, there are big grief components to this. And then I'll open that to Dr. Weber, Dr. Griffin. Do you want to say any more about that, either from the interventions you've worked with or your clinical experience?
Yeah, so I have noticed the overlap as well, and I think that's that because there's a lot more research that has been done on grief, that in the development of interventions for moral injury work, we maybe can borrow from our colleagues that have more traditionally been classified in grief. But I think one of the pieces that overlaps for me is in grief work, there is often an inability to contact the other people who are involved in this, right? Like the person that you're grieving is deceased and you're trying to like figure out how to move forward with your life in relating to them in a new way. And oftentimes with moral injury, that is also the case. So a person may feel like the guilt and shame that they have is motivating them to make amends, right? That there's this big gap of injustice, and if they could just make some reparation, that injustice gap would be less. But in the case of like military, when a person maybe is on the other side of the planet, or they could be deceased. Also in healthcare, they could be deceased, or that there are regulations like the Health Information Portability and Privacy Act that would prohibit a healthcare worker from reaching out to a patient, that there are these barriers to amend making. And I think as spiritual leaders, as mental health care professionals, one of the things that we can do best is by helping folks who have sustained a moral injury to reconnect with those natural processes of reparation and reaffirming the connection they have to their important values that were violated by overcoming these barriers and maybe seeing them in a new way.
I'll just add real quick, because you all are coming up with a lot of good examples of overlapping concepts and overlapping problems that are, like I said, you're picturing examples where these other things would be coming up as well, like PTSD or grief or guilt, and all these different overlapping concepts. And I think that's partly because these potentially morally injurious events are, I mean, they're like by definition, they are sort of messy. Like by definition, this was a situation where different beliefs and values were in conflict. And so they were by definition very complex situations. You know, denying visitation to somebody in order to keep others in the hospital from getting infected, when that also means that someone is going to die without their loved ones by their side. I mean, that's by definition a complex, messy situation. And that's partly why we could probably think of almost endless examples of other overlapping you know, psychological problems or spiritual problems and things like that.
Yeah, well, thank you everyone for joining us. We're 11 minutes after the hour, so I think we will move towards closing. I know that we didn't get to everybody's questions, but we tried to address a number of them. As has been put in the chat, the recordings with the slides will be available if you want to follow up on this. And the paper is accepted for publication, but it's not published yet, so it will be forthcoming. If you Google Dr. Weber's name and moral injury and keep looking, it should come up soon in terms of being able to check that out. So thank you, Dr. Weber, and thank you, Dr. Griffin, for being here this afternoon. I wish you all a wonderful day, and may we continue to work in these spaces, and I will quote Frozen today, and continue to do the next right thing, so to speak. So thank you all.
Thanks, everybody.
Thank you all. Take care.